we have Dr. Madison Berl. She's the Director of Research for the Division of Pediatric Neuropsychology at Children's National Hospital and Neuropsychologist for the Comprehensive Pediatric Epilepsy Program. She's going to talk on Beyond the Seizures, Family Impact of HH. Welcome, Dr. Berl.
Hello. And Kathy, are you going to tell them my mistake? I'll tell them my mistake. So
not a mistake. It'll be good.
It'll be fine. We'll be fine. And nobody is alone in having executive memory problems. My carelessness was an attention problem, and as you can see from my title, I wrote Beyond Seizures. So the family impact is not the core focus of this talk. However, I do think based on what the prior Dr. Wethy was talking about, I think this will be a nice segue and complementary. And we can certainly with questions, and I will fit in how all of these things really impact the family. So as well as the person with HH. So we know that to be true, and I will make note of that. So thank you for having me. Thank you for spending some of your Saturday time with me. So my plan was to go sort of really get a comprehensive view of what does beyond mean. There's a lot more things to deal with than just seizures or the tumor itself. So that's what we're going to focus on. In particular, I'm going to do a review of what do we know from the literature about neuropsychological outcomes in HH, as well as other outcomes, and then what can we do about it in terms of recommendations. And hopefully that will, I'll keep us on time with that. First of all, what is beyond? So just sort of a brain-based point of view is where I work from. So any anomaly in the brain or injury, whether you're born with it or it comes about, can impact all sorts of areas of functioning: behavior, language, thinking, motor, and emotions. And really that's because of the interconnectedness of the brain. So even if you have a very focal area like a hamartoma in the hypothalamus, that can affect so many other parts of the brain. And what these beyond areas often are referred to in the medical community as comorbidities. And really just that word just sort of means they often co-occur with that medical condition. And there can be a range of comorbidities. So I'm going to be talking about behavior, language, thinking skills, and emotions, but you could also think of sleep problems, risk for SUDEP, appetite problems, all sorts of other issues that we know co-occur. And so just kind of giving you an overview of that, which again, many people already know and live it. The other thing that I think can be confusing for some families, and I think was brought up even at the end of the last talk, is who do you go see? And sometimes, I get called a psychiatrist all the time. I'm a neuropsychologist, and who do you go for what? And so actually part of that confusion is because there is some degree of overlap. And so there are several specialists who evaluate and can help evaluate and treat those cognitive or psychosocial problems. Again, that's going to be my focus for this talk. A neuropsychologist, in terms of evaluation, covers them all. We're going to do a little bit of language, a little bit of motor, cognitive, language, emotional. We're going to kind of do more of a comprehensive landscape. That's why our testing days are quite long and sometimes last over a couple of days, because we're really covering all of those areas. And then a psychologist has the same degree as a neuropsychologist, a PhD. The neuropsychologist went on to specialize more in evaluation in those brain-based behavior. A psychologist can do assessment, but they are also usually equally good at the therapies and the treatments. And traditionally, you think of a psychologist as focusing on those emotions and behavior and family dynamics. So that's where that therapy comes in. Again, a psychologist can do evaluation to see what degree of emotional distress, or they could do some things in terms of cognitive functioning and things like that. Then you have your psychiatrist with an MD that really also focusing on those behavioral, psychiatric, emotional problems. And their primary mode of treatment is prescribing a medication that might help with that. So often a psychologist and psychiatrist can work together if one is more focused on therapeutic and the other is focused on medicines. And you may see a psychiatrist less often, where a psychologist you might see every week. Then you have more specialized therapists and evaluators in certain domains. So speech language pathologist is definitely going to dive deep into those language issues. Also, they are more likely to be the ones doing the therapy, which could be weekly or every other week in schools, those kinds of things. But anything language based. And then occupational and physical therapists are really focusing on those motor skills. Occupational therapists you usually find in the school, they are a little bit more focused on, tend to be fine motor. It's not completely, but basically the daily use. How do those motor skills impact that person in accessing school or work or things like that? Versus a physical therapist is a little bit more focused on those gross motor skills and more strength. And again, daily use, but it may be more about, walking or bathing or getting into, doing other kinds of large movements, and how can they have devices to help them or strategies to increase that strength. And then you have your developmental pediatrician, which is a pediatrician that's a little bit not as much of a generalist, but they're really focusing for kids on development. And that can be a good place to start if you have some concern and you're not sure where to go. That can be a great person to start with. And they may do a little bit of testing. And if they feel comfortable, they may give a diagnosis right there. But a lot of times they're saying, this is what I'm seeing, and this is how I would follow up. So that can be helpful. The other kind of general strategy is, at least where I am in Washington, D.C., all of these folks have long wait lists. So sometimes one strategy is just to see who you can get in with first, because you may have to wait, and you may have problems that cover all these areas. And so you may need to start with that. See them all, or see several of them. So hopefully that's a little bit helpful. There are specialists who have a little bit more understanding in their training of understanding that brain and the context of developmental change. So how things might change over childhood, adolescence, adulthood, and into aging, and with treatment. So the question that was before about, okay, if you have a memory impairment because there was a surgery, is that harder to get back because that structure is actually gone and severed, versus the seizures, which may not have completely severed that structure from the connecting with other structures. And there are potentially some differences in how much you're going to be able to get back with that. So again, having someone have that understanding of what your child is going through with that medical context can be helpful. And there's, again, variability in each of these disciplines of people having experience with that. Just to cover the domains of functioning, we talked about memory and executive functioning before, but there's quite a lot, and all of these again sort of intertwine. And just to quickly go through and thinking about, when you think of a primary deficit in this area, that may lead to a particular diagnosis. So we think of just overall general problem solving skills, cognitive functioning, often referred to as IQ or intellectual ability, that if there's a global problem with thinking and remembering and just sort of power, intellectual power, you're thinking of an intellectual disability. And that sort of sets the context for expectations and maybe what you think someone should learn. Attention problems definitely are always something we think of, and that can lead to memory problems in and of itself, especially in children. The diagnosis there is ADHD, which I think a lot of people are familiar with. Executive control, you guys really heard a lot about that. Again, it's a hallmark of ADHD, but a lot of other disorders as well have executive issues. And I just think of it also as that sort of step up in demand. So it's not simple attention, it's complex attention. And now you have to shift and regulate that attention, as well as working memory, initiation, inhibitory control, organization. And you kind of think of that as that regulation. So it can certainly affect emotional regulation, cognitive regulation, and behavioral regulation. Language, we all are very familiar with that, both expressive and receptive. You think of pragmatic language, so that ability to use language in conversation, and articulation, just kind of more of the motor aspects, of language. We have visual or nonverbal processing, memory and learning. We think of dementia in adults. A core memory problem in kids is pretty rare. With HH or other seizure types, that's the one time we do really think about it in kids. Usually it's an attention problem that leads to a memory problem. So that's one thing we're always trying to tease out. But again, if you have a fundamental brain reason why that might be occurring, it's definitely core to who we are and what we expect of kids too. Motor issues, academics are going to lead you to specific learning disorders in reading, writing, and math. Also, some people know that more as dyslexia, dyscalculia, or dysgraphia. Those are very interchangeable terms, just different older terms. Social and emotional functioning, which definitely autism spectrum disorder, the core features of social deficit, depression, anxiety, and then disruptive behavior disorders. And then adaptive functioning, sort of what we do in our life, how do we put those skills into action, and how does that impact us? Just again, sort of things you should expect with an evaluation, and no matter what discipline, they're going to take some sort of history. They're probably going to do some sort of testing, and really you want that person that really doesn't just read the numbers, but understands and observes your child to as we know, tests are imperfect. They don't measure everything. I don't have a hard worker test. And I know there's a lot of kids that do really well because they just persist. And so those are the kinds of things that you want to have the evaluator appreciate, and especially in your report, so that whoever they're working with, a school teacher, a therapist, knows this about your kid. They're going to do an integrative summary of those findings placed in the context of all of this, the medical, developmental, and psychosocial history, give you diagnostic formulation, give you recommendations, which is the key thing, and then perhaps say, we also need to work with these other people. So again, all these disciplines are aware of what other disciplines do really well, and we do work together. So having a team is more than likely, given that HH is not just one single discrete problem. All right, so who should you look for or ask for specific to HH? So this came up again in the other one, but you're dealing with a rare disorder, and so you can ask them if they have any experience, but it's very possible they don't, or not very much. And so how can you broaden that to sort of feel like you could trust them? And so as Dr. Weather was talking about, like that person having a heuristic or understanding based on other things that they know can really be helpful. So other medical, other kids with seizures or similar populations, do they know, again, these different areas of the brain and how they are related? Do they have the framework to understand that? Prader-Willi syndrome has a hypothalamus involved, also a rare disorder. There's some shared behavioral features, autism, intellectual disability in general. And then, as mentioned before by Lisa, traumatic brain injury populations deal with memory problems all the time. So someone that has that based on the problem that you are seeking help for, you may be fine with someone that has some expertise in a slightly different area, as long as they're understanding what you're bringing to it. And then again, just experience with the problem you're seeking help or evaluation for, whether it's more the behavior and the rage and the aggression, a memory problem, an attention problem, language, anxiety, whatever it is. That's sort of my, again, general advice to finding that person that's going to be effective. All right, so what do we know? So I know some of you guys may already know this pretty well, but I like to just put it out there and give an update just in case people, there's some families that really delve into the nitty gritty in the literature and then others that don't. And so I'm just going to kind of give you a quick summary. So basically, risk factors for sort of cognitive outcomes is really there's the most literature out there about that, as opposed to family functioning or psychiatric outcomes. There's very few, and I'll get to what there is, but there's very few. So we're going to start with what there's most. In some ways, the risk factors aren't that different from epilepsy in general, because so many kids with HH do have seizures. I will say that's probably a major gap, is that I don't think there's many studies, if any, that are specific to HH without seizures. And so if your child doesn't have seizures, I would say generally, hopefully they're probably doing pretty well. That earlier age of seizure onset or having more seizures is a risk factor for more problems with cognition. Having a larger lesion size, having comorbid behavioral problems, having to take more medications that can affect thinking, also is sort of an indication of the burden of the disease. And then different surgical approaches. These have changed over the year. There are also a lot of other factors people have looked at in terms of the surgical approach, but I won't get into those too heavy. The other sort of common finding is if you're higher functioning pre-surgically, you may be at risk for losing more later. There is sort of the advances in surgical techniques, specifically laser approaches, has really changed the game in HH outcomes. With no surgery, most HH patients were worsening and deteriorating, and at least with any kind of surgery, much less laser, that stopping that deterioration has been shown. The first published report of the laser surgery was actually not that long ago, only, and this is in children, sorry, in 2012. I am a pediatric neuropsychologist, so I apologize if I'm a little kid-centric. If you're, again, reading articles, be aware of when and what the technique was for the patients in the study. So the technique and the outcomes were a lot worse before, and now they're getting better. And again, I'll show you some more recent ones. The terms can be confusing. So there's lots of terms for referring to the laser surgeries. There's stereotactic ablation, laser interstitial thermal therapy, RF, gamma knife. So just be aware that those all have they're slightly different, but a similar approach, a little less invasive than a resection. A recent systematic review of seizure outcomes across 12 studies and 185 patients was that 69% were seizure-free, and an additional 7%, 7.5%, so we're almost up to over 75% had substantial benefit. So this is, again, the outcomes are really much stronger for the laser approaches. These are all the studies that I can find that have a cognitive outcome. There's going to be other studies that talk about surgical outcomes and other issues, but these are the ones that have talk about those surgeries. And you can see over time, these do go up in percentage in terms of improvement, in terms of seizure freedom, and then they're variable in terms of whether they look at memory specifically or if they're just looking at IQ. You can also see the number of kids that are low to begin with in terms of the kids going to surgery. So having an intellectual impairment doesn't prevent you from benefiting here. That's sometimes a question that comes up. I'm going to focus on these last two studies that are a little bit older and specifically only laser surgeries. So again, just be aware. Also be aware sometimes these differ because seizure outcomes can have a rating system. One is none, absolutely no seizures. That's what we're all going for. However, an ANGLE outcome 2 means that you may have a seizure, but it really isn't super disabling to you. And even though it's there, it substantially improved your life. So a lot of studies kind of talk about both 1 and 2 outcomes because those are quite good improvement. So the 2017 study was the largest study solely with patients who had undergone laser. The technique they used was the radio frequency. The surgery occurred between 1997 and 2014, and they achieved 85% seizure freedom. They focused only on IQ, so intellectual, and again, sort of what this shows you here, the red line is sort of the marker of intellectual impairment. So what you can see is that this is the intellectual impairment preoperatively, and then postoperatively, the change. So if there were some people that didn't change. Most people were improving in their outcomes. And of the people that changed, there were only very few that I would say that would be over 5 points is going to be beyond the measurement error of the IQ test. So anything in here is kind of just usual test retest variability, but something down here as well as above that 5 up here are true change and true decline. So again, that's really nice to see. So again, going from preoperative IQ to postoperative, on average, you're going up. Again, there's maybe some slight benefit for the higher functioning kids, but again, the lower functioning kids also are improving by 6 points on average. So that's really good news. Again, this is kind of showing who improves over time. The children who really got rid of their gelastic seizures improved most by an average of 9 IQ points. But if you had continued gelastic seizures, there was still some improvement, but it was in that measurement error. There was more improvement sort of in this mid-range of IQ. And this black line kind of shows the gray line is the first post-operative visit at a year, and the black line was for anybody that had been seen again. So what's nice to see is you see these gains continuing. So even on that first visit, they've had a change, but those continue to go up for many of these kids, which is really an important point, which I'll talk about in a second. The other big study was a recent study, 39 patients, and they had the 3-year follow-up. And that 3-year follow-up, that long-term follow-up, I really want to let you know how important that is. And it's really changed my practice when I talk to families, because no matter what, I work with kids with epilepsy in general. And when they have surgery, I used to say, most kids won't change. And that is true when I look at them a year later. Most kids aren't going to decline and they're not going to improve. So if you're going in thinking, oh, we stopped the seizures, all of a sudden my child's going to be a genius, that's not going to happen. Or return to normal if they were having struggles, that's probably not going to happen immediately either. But there is lots of incoming evidence now to show that improvements do happen, but they tend to happen on the order of 4 and 5 years after surgery. And that's 2 different cohorts show this. One is in the UK at Great Ormond Street, and the other is in Canada, where they're able to follow kids a lot longer than we can in the US. So I just want to really highlight that has a lot of implications for not giving up on a kid, because just because they had surgery at age 10, 5 years out is 15. And a lot of schools say, they're done, they're not going to learn much more. And I would just really do your best to fight against that, because that's actually probably right when you're going to be seeing some of those improvements. So that's my soapbox there. But anyway, this study did a 3-year follow-up, and that was very important given their approach, because in Gamma Knife, there is a known difference with other laser techniques that you're going to have a delay in seizure to the time that seizures stop. And this study in particular, it took 17 months on average for kids to stop having seizures because of this approach. And that ranged from 4 months to 3 years. So again, depending on what you're doing, be aware that you might have to be patient, which is very hard when you have a child having seizures, but you may see more improvement later. All had IQ, just like the last study, but they also looked more specifically at working memory, processing speed, and memory, which the other study did not. Performance was a standard deviation below average in a majority of this population. So again, a lower functioning group, which is similar to, I think that's like HH as a whole population. Post-surgical freedom was 44 for that angle 1 and 33 for that class 2. So again, about 77, you would say, would have really good outcomes. So what they found is that, interestingly, and when they say somebody improved, they're saying by a standard deviation, which is a lot and way beyond what is the retest reliability. And so I believe it. It's clinically important. So 46% of these kids 3 years later had an improvement in working memory. And 39% had an improvement in processing speed index. What you see is that those percentages are much lower in IQ. And what I think it's important to understand is these are a different set of skills. Working memory and processing speed are the first ones to go when you start aging, have an injury, you take a medicine. Those are very much more variable skills versus IQ, which is a very solid, what we kind of call the hold skill. And that's because it's over time, it takes longer to change. And so the fact that these two skills are changing first has a domino effect on those longer term skills like IQ and memory. And remember, IQ is really a reflection of that long-term storage. So the fact that they had some change, but not a lot of change, is really important to notice. But I expect that if they were to do this evaluation again later, they're going to have even bigger changes like the other study showed, a larger percentage of change. Again, learning trials are just like, if I tell you the list or the story, you're going to tell me right away. Delay in memory testing is, can you remember it 20, 30 minutes later? So they have a lot more improvement on learning, which requires that working memory and attention, but the delay is a little behind. But again, I think that will also improve if they were to test these kids again a little bit later, patients. This was a big age range of kids, people that went under surgery, laser surgery. The factors that influence better outcomes was having fewer seizures, having a change in seizure frequency, and that shorter time to cessation. So if they were closer on the 4 months where they stopped having seizures versus 36, then they were doing better, and then having to take fewer drugs, anti-seizure medications. Okay. I know I'm sort of near my time, so I'm going to skip through this one. This is an older study. Again, I just want to be aware. They found more declines, but they also have a mixed seizure group. And so not so much in intelligence, but in their learning, processing speed, and cognitive flexibility, which is a really important skill of being able to flexibly go between two tasks and gets us to those higher order skills like executive functioning. Sort of in summary, seizure freedom is going to stop that IQ loss, and then we're going to see those improvements beyond a year and even farther out. Working memory and processing speed had those large improvements. But there's limitations. We're not looking at behavior even if you didn't change anything in cognition, behavior might have changed, or just caregiver stress, because now you don't have to worry about managing the seizures. So that's an important gain that's not necessarily captured here. In terms of psychosocial functioning, we have very few studies with large samples. There's these 2 reviews, which I'm going to go over, and basically they say, you know, there's a majority of these cohorts when they're looking at kids compared to kids that have seizures with kids with HH that have behavioral aggression compared to kids that have HH without behavioral aggressions. They look at that and they noted that being male, having a younger age of onset, having more intellectual disability, and having a mixed seizure type, not just gelastic, were the factors associated with that aggression. You can see there's a range of disorders that were found in the Great Ormond Street compared to the systematic review. So Great Ormond Street is in the red and the systematic review is in the turquoise. But again, externalizing disorders, that ADHD, that conduct problems, defiance, rage, that's again in either study associated with having seizures, having intellectual disability, and being male. They also found, though, that they felt like the intellectual disability itself sort of mediated that epilepsy factor. So if the epilepsy was really the thing causing the intellectual disability, then that made that person less able probably to handle stress, right? And so that's what they found mathematically. Internalizing problems, the anxiety, depression, those weren't associated with any particular risk factor. I'll just take a second to talk about rage attacks. These are, if you don't know, very explosive episodes, very hard to manage, very hard to predict sometimes. There's hypotheses about why aggression and rage. I do think we need some better definitions and terms about what rage is. One family may think one behavior is rage, another may not. I will say I think most families understand it as something very intense and without ability to calm it down. There's one hypothesis that is really secondary to some sort of frustration the person is feeling, and having low tolerance for that, and really then sort of having this affective aggression of acting out. This is in contrast to what some psychiatrists refer to as predatory aggression, where you're actually more overt and intentional in your aggression, you know, that you really, there's a sense that you have ability to control that behavior, and there's planning and things like that. And stealing, I will say, having experienced some affective aggression, the longer it goes on, it feels very predatory after a while. But I think the start of it is a little bit of what we're talking about. Again, is there a role for autism or intellectual disability as part of this, just that they don't have the cognitive resources to figure this situation out. And so that frustration builds, and the behavior comes from that. There's other thoughts about whether precocious puberty or that growth hormone deficiency may impact the showing up of rage attacks. That wasn't found as a significant factor in the review that I just showed. So that link hasn't been clearly established, but it was just a thought. Again, we talked about why these things happen and where they are in the brain, that you can have the memory problems, the rage. These are all quite close in the brain and connected. Again, we talked about this. There's this plasticity that we talked about, that long-term outcomes. There's a better opportunity for recovery when you have an injury or that surgical intervention younger, or laser intervention. And seizures stop earlier. Again, there's some things that you're never going to get back. Hemispherectomy, for example, you can have recovery of language, but you're not going to get that motor back. And so there is a difference in what might be cut or taken out. Again, I talked about the Canadian and UK studies, that long-term outcomes, you don't see an IQ improvement until around 5 years, which again is hopeful. Even though it's painstaking, 5 years is a long time for a kid or anybody. In areas that are still under development, like those frontal lobes or the hippocampus, we have a lot of growth. And whenever you still have growth, that's an opportunity for rehabilitation and continuing the therapies to make those areas grow and continue to mature. Okay. I am so sorry because we're here, but I do think you taught, we talked about some of these with Dr. Wethy. I'm going to give you one more general advice here about asking for help and getting support. That can be in a lot of different forms, and whether that's the medical field, just education, just knowing more about it can be incredibly helpful to understand the reason why your child is, raging on you is not because they intentionally are doing something new. That is their brain that is not giving them the tools to be able to react appropriately. And having that education can really help someone's mindset. Not every minute of the day, but it can help. Medicines are there. They can be sometimes helpful. Surgery, knowing other families through those medical providers, and having a multidisciplinary team that works together, because usually one professional can't figure it all out. Therapists, whether that's for the behavior on the week, with a family specifically, providing support for parents or marriages or siblings that are in distress. School, that, making sure that they are making an individualized plan for your child to address their needs. Having extended year services gives you a little bit more respite, and learning new skills, having that peer group, and sometimes that's the motivating group. Using your community, state, and federal services. You may get home-based therapies, transportation, something as simple as that, but important emergency services. If your child is very aggressive and you need someone to come right now and you don't know what to do, there are crisis intervention teams. Respite, again, everybody needs a little bit of a break. Wraparound care so that they're coordinating both with your medical and at home. There's waivers, and then just recreation and fun, and being able to find a camp that works for your kid so that they can go to camp like every other kid, or do outings, horseback riding, all those kinds of things. And then, of course, you already know about parent organizations because you're here. I would say there's specific to HH, but even other groups can be super helpful depending on what you're dealing with. Okay, I'm going to really stop now. Sorry.
No, thank you, Dr. Berl. I hesitated to jump in here because the content that you have presented is such a good complement to Dr. Wethy, and I think so important, and is addressing a lot of the questions that we had anyway, especially in the wrap-up slides were fantastic. So I'm just going to throw a couple out there, and then fortunately, families we have recorded everything, can go back to this presentation, go through it, and look at some of those slides that you presented with some time. And we will definitely get back with you about a webinar to flesh this out some more.
And just, you're sharing the slides in my recommendations. There's like at least 20 websites. So perfect. People can also, because I couldn't, you can't go through all of it.
That is awesome. That's fantastic. And we will definitely share those in a multitude of formats. One question, do ADHD medications help for focus even if you do not have that diagnosis?
Yes, they would even help me, not so that I wouldn't have missed the title of the talk. So that's why college kids use it, and it's on the black market. It helps anybody that takes it actually. So yes.
That's interesting. That I was not aware of that. What do you suggest for individuals and families whose biggest struggles are mood and behavior? That would be addressing both the younger and the older patients.
Yeah, so again, my general thing is to get help. I think there's a lot of strategies out there, and even just going to the therapy can be helpful release, because it is stressful. And behavior with little kids when they're not reasoning is more about the parents and how can they learn strategies in the moment. You're not going to do talk therapy with a kid, a little kid. And especially if your child might be a little bit lower functioning, your expectations for them. And sometimes that's what you need to adjust. Like I had a big kid who looks like he should know better, but he wasn't functioning at that level. And I'm sorry, I keep referring, I will disclose, I know Lisa and Kathy know this, I have a 14-year-old with Prader-Willi syndrome. And so some of my experience, I speak at my parent mouth and then sometimes that as a psychologist, but I can tell you, even as a parent who is trained as a psychologist, you forget and you need that bounce back and perspective to say, am I off expectations here? Could I do something else differently? And so I think that is one of the best ways you can to help your child and help yourself manage that.
Perfect. Well, we are at our time. I hate to have to end this. Thank you so much. It was serendipitous that your topic maybe was not exactly the title, as you covered everything beautifully. So thank you so much.